in the spotlight, ECU Health and the ECU Health Medical Center. We're very honored to have a couple of the high-ranking officers from our local hospital system here. Brian Floyd, who's the Chief Operating Officer for the entire ECU Health System, and Dr. Leigh Patterson, who is Chief of Services for Emergency Medicine at ECU Health Medical Center and also Chair of Emergency Medicine at the Brody School of Medicine. Good morning, folks.
Good morning.
How are you? It's nice to see you. I'm just meeting Dr. Patterson for the first time, but as always, it's always great to have Brian Floyd in here. And a lot we can talk about, get an update on what's going on at the hospital. And I'm sure with flu and COVID season upon us, you guys are gearing up, right?
Yeah, no question. We're in that time of year where we can anticipate seeing a surge in volume of patients that come through our services, including our emergency department services. And we wanted to just spend a little bit of time making sure the public understands what's going on in our hospitals, especially related to emergency services. One, so that they understand the context of that. It helps people to know what's going on and no mysteries about it. Secondly, we know that there are patients that often are waiting longer than we're happy about. And yet, that challenge is something we should just address and talk about why that's happening so people better understand. And also that people know how to use the services, and so that we're best able to take care of the public when needed.
The biggest complaint, I'm assuming, that you get, Dr. Patterson, is wait times, right?
Yes.
People come to the emergency department, and I hear that from time to time, that people, get stuck in a room and have to wait a long time. Address that for us.
Sure. And first off, I would tell you, we really do not want our patients to wait any amount of time you're waiting. Waiting in the lobby, I think, is honestly the biggest complaint I have. I waited a long time to get seen. And every time I hear people say that, I am so sorry. I mean, that's our first experience if we don't want you to wait. But we do get patients seen quickly that really need to be seen quickly. We see more than 300 adults and children every day at the medical center in that emergency department, and the patients who are there for the highest acuity emergencies, things like strokes, heart attacks, major traumas, we have those patients back in minutes that are seen. We're meeting and in many cases exceeding national guidelines for treatment for those high acuity patients. For the other patients who aren't coming in with those immediate life-threatening emergencies, we have a well-established triage process for getting them through. I think what many people don't yet know is that during the week, during the busiest times when the largest number of patients are coming into our emergency department, we have a doctor stationed in triage now that's supporting the nurses doing triage. We have protocols that nurses can initiate so that even if you are waiting in the lobby, you are most likely getting additional testing. You're going to see a paramedic and have blood drawn. You're going to go to radiology for x-rays and sometimes even CAT scans and ultrasounds so that we can maximize that wait time before you get seen. And there are doctors and a charge nurse really constantly scanning that lobby, looking at those results, reassessing patients. We're rounding in the lobby to check on patients, and we're monitoring who needs to get back next. So there's a lot of attention that I think many people can't see when they're in the lobby that's being paid to that group of folks who are waiting.
Brian, we talk all the time about the volume of patients that you see in here in Greenville at the medical center, and it's enormous.
Yeah, I say this all the time because the public should understand this. We are blessed to have a tremendous resource here in Eastern North Carolina in Greenville that is actually really, really unique. There are not many academic medical centers in the country. With those academic medical centers comes incredible specialization. This is a level 1 trauma center, meaning it's the highest level trauma offering for emergency care that is available in the United States. We just last year became pediatric level 1 trauma certified. There are only 3 of those in North Carolina. And so with those certifications comes physicians and specialization that are really highly unique for 24/7 highest level of care. But because of all of that, we also have a medical center here that's overwhelmed in volume. We're more than a 1,000-bed hospital, and every day we're full. We're operating fully. What we've now been experiencing with that volume, over 100,000 people in just this one emergency department every year.
And Eastern North Carolina, in certain pockets, certainly here in Pitt County, is experiencing growth.
Right.
And it's going to get worse.
We had from last year to this year, Henry, just last year to this year, 8.5% growth in volume at the medical center. And on a 1,000-bed hospital, that's 80 patients a day. That's larger than any of our other hospitals are occupied every day. And so what you're experiencing is, even if we catch up from COVID and all that, catching up in staffing, which is happening,
Yes.
and we're in a better place than we've been in a long time on staffing. But if you grow that much, it's like having to open another hospital over the course of the year to deal with the patient volume. And as I always say, when you have more transfers coming into the medical center from other hospitals, which we had 1,700 more patients transferred this year than last year, and you have a growth in volume, and the emergency department is growing in volume, and you need to admit more people out of those patients, then the hospitals being full manifests in wait times in the emergency department as we have to triage those patients. And so that's what's being experienced here. And this is a national issue. All hospitals around the country are facing this, particularly those large academic medical centers. And the ones with the most challenging situation are the rural hospitals. And as we know, we have rurality all around us that drives these conditions and issues that overwhelm our organization. But what we want to make sure the public understands is, when you have that life-threatening issue, we're designed for that at the maximum level, and there's a great efficiency to those patients. Most all of us that live here will hear a helicopter every day.
Yeah.
There are 5 of those helicopters.
Yeah, we're right here across the street from you. We see
Right.
those helicopters going in and out every day.
Those ambulances and those helicopters.
How many helicopters now?
There are 5
Yeah.
helicopters. We're about to have 6. And at the end of the day, they're not bringing low-risk patients. They're bringing those very
Yeah.
high-risk
If someone
patients.
comes in here on a helicopter, they need
That's right.
immediate
and
care.
every
Yeah.
time it lands,
Yeah.
whether it's a child or an adult, our teams, Dr. Patterson's team of specialized folks, that they drop everything and they go and attend to the life-saving issue that's needed at the time. But when you're the waiting patient in the lobby, that sometimes
It's
just keeps getting in front of you.
I have what will potentially sound like a stupid question. Why not open another emergency department? Is it a cost issue? I mean, why not just enlarge the amount of space and number of caretakers that you have to accommodate the need?
I think that's one option to do that, and we certainly are monitoring, looking at that growth that you're talking about across the county. We monitor that volume and where it's coming from to see, is that something we need to think about? One of the strategies we're doing in the new year is opening an immediate care, something that's going to be able to provide people another opportunity to seek care for what they know to be lower acuity kind of complaints. The second option we've done is expand our lower acuity area in the emergency department and open those hours until 3 a.m. so that we've added capacity. But I think that is a shorter-term strategy. We have patients who need more primary care options in this region longer term to really grow a healthier population, and that's a big part of the strategy
Do
that
you
the
need
health
more
system
staff?
is pursuing.
Is it a staff issue?
Not in the emergency department. We've had great years the last several years recruiting both physicians and a number of subspecialist physicians in the emergency area. In pediatrics in particular, we now have 8 physicians who are additionally trained to focus just on pediatric emergencies, and our nursing recruitment's been excellent as well. So I don't think it's a staffing problem
No,
for
I think
us.
it's a staffing problem when you consider growth,
Yeah.
but it's not the staffing problem people believe. In fact, last year we had one of our best retention years. We are leading the nation in the top 10% for retention of staff. We hired over 2,000 nurses last year at ECU Health. We hired over 200 physicians last year that have joined us here. We have great momentum in team
200
building.
physicians?
Yes.
Last year?
Right, and so the
Wow.
concern that people hear, around the fringe of these issues and things people kind of talk about are actually not what we're experiencing. We're actually on an upswing. There's momentum in building ECU Health team members. The challenge is, of course, we're recovering from COVID. Not only did people have to recover from COVID, the organization itself is having to recover from the strain of what we've been through, both people who retired, loss of people, income, the finances of the organization. We are now helped by things like Medicaid expansion and all. We're in a different position now to reinvest in what's required to be able to grow further and help solve that. And what Dr. Patterson said is just so important. The issues that we're dealing with are not as simple as just patients coming to the emergency department, and so build a bigger emergency department. The reality is it's a total care model growth. When people during COVID didn't get care, we now have them all coming back with later stage, more complex issues that we have to deal with. And so we're pushing primary care, as she said. Last year, we opened up 1,000 more visits a week in our primary care setting. And even that still leaves us very short the amount of primary care access that people need, given this region and given those that we serve here. And so growth is a long-term strategy here to try to get more care to patients. Even Brody School of Medicine's growth of 30% student populations is ultimately about training more physicians, particularly in primary care, who will practice in a rural market like this.
What can the public do to help? Are there people coming to the emergency department at the hospital that should not come there?
I think they're coming to the emergency department and they could get the care they need in another setting. I really would be reluctant for anybody to hear the message that they shouldn't come to the ED, because everybody I see needs care. They need care,
Yeah.
and we're there and we'll get to them. So I don't want to discourage anybody from coming there, but yes, we've got some folks who could get their care, who could get the right level of care in a practice setting. We'd love to see people really growing and establishing their relationship with their primary care provider, so that they are getting the care that they need, that they've got access, and that they're looking at other options. Most of our practices have additional after-hours options to contact your provider. There are virtual options, so there's some options out there to take advantage of. I would love the opportunity to encourage everybody who hears us to get a flu shot. There's still plenty of time,
I
and we
just
can
got
bend
mine.
that curve.
Good.
I think that's something in the short term, thinking about the season we're heading into, that folks can
Yeah.
do, but really establishing that relationship with the primary care is excellent.
Speaking of that, I just got my flu shot. The COVID shot, of course, has become quite controversial. Let's don't get into that. But I just got a flu shot, and my doctor said because I'm over 70, I should get an RSV shot.
Yes.
So is RSV on the rise? Is that going to be a big problem this winter?
I think RSV has been a big problem for the last several years, and just as an odd side effect of what we did in COVID, that we recognized that adults were getting RSV too. We really thought it was only affecting young children, children under the age of 1, but it is affecting older adults as well. So yes, we absolutely encourage you to get an RSV shot.
I'm marveling at the fact that you actually hired 200 nurses and 200 doctors in the last year.
2,000 nurses.
2,000 doctors?
doctors
In the last year.
in the last year.
That's incredible. Which leads me to a question I've been wanting to ask you, because we haven't talked about this recently. We talked about Medicaid expansion so much before it happened. I'm not sure I've had you on since we've actually experienced Medicaid expansion. And it was expected to be, I don't know if we're going to call it a windfall, but it was expected to be a big financial boost to hospitals like ECU Health. Has it been?
Yes, I mean, the reality is, well, a couple of things about expansion. First off, expansion just means that there are uncovered patients who now can get Medicaid, right?
Right.
And so you don't experience
And those patients were coming to the hospital before Medicaid expansion
right.
and couldn't pay.
and it was a cost. So we write off nearly $200 million of unpaid bills every year at ECU Health. We are one of the highest of those in the nation because of the market that we are serving, a very underserved poor region. So it was particularly important to us that Medicaid expansion happened to help us with this challenge in our region. So we'll experience the benefit of that in two ways. First, as those patients come through the system, they have a way to pay. Long term, and the more important issue is, as they have a payment source, they then see doctors and get their medication and get better care. Then, as Dr. Patterson always talks about, over time, you have less utilization of emergency services and things because the patients are more well. And that's the key goal of Medicaid expansion. There's also the HASP payment multiplier that's attached to Medicaid expansion that brings in additional dollars to help support hospitals. And of course, through COVID and the amount of losses hospitals nationally have been experiencing during that pandemic, it was really important to us just to stabilize our financials so that we'd be in a position to invest in the growth of people and technology and facilities to help deal with growth that we're experiencing in the future. So we've gone from, when I was on here before, red ink on our balance sheet, where we were losing money every year, a significant amount. Well, I can't borrow funds when I'm losing money to go be able to build more facilities or enhance our emergency services or new ORs or beds. So, it was really important to have financial stability happen so that we're in a position to do what we need to do. And not only did Medicaid expansion help that, but our teams have been rigorously working at operational improvements across our health system that produced nearly $90 million less cost of doing business just
Yeah.
last year. So if you couple that improvement in our cost position plus better efficiencies in care, which we're seeing, lower length of stay and patients moving through faster because of higher quality. All of those things are working together to help us be in a better position, and then HASP and expansion are certainly adding to us.
You know, it strikes me that getting Medicaid expansion done when it was done this past year
Right.
has been really important, especially when you look at the legislative session coming up in 2025. They're going to be dealing with a lot of problems.
Yes.
Because of Hurricane Helene.
That's right.
And money's going to be tight in Raleigh, and attitudes are going to be different. So
Yeah. Well, and
it's probably a good thing it got done last year.
you know, and
right?
hospitals are important to the public's well-being, but they're also important drivers, particularly in a rural market, of economics.
right.
And so if they're not doing well, the communities don't do well.
Yeah.
So getting this so that ECU Health, which, you know, covers operating all these hospitals where they might not be financially stable on their own.
Right.
Is really important to Eastern North Carolina, and we couldn't have done that without the Medicaid expansion work.
I also wanted to ask you about the news that broke earlier this week that our friend Steve Lawler, who was the president of Vidant Medical Center before you, and is leaving his job as the CEO of the North Carolina Hospital Association. And I know that Steve was a big part of getting Medicaid expansion. You also, I mean, you were a big player in that. You're on the executive committee of that operation.
Okay.
But Steve is retiring now. He's my beach neighbor. I've seen him on the beach recently. He didn't tell me he was retiring. And
Unfortunately, you might see him more on the beach.
And Josh Dobson, who is the labor commissioner who stepped down last week, has accepted the role as the new CEO of the North Carolina Hospital Association. I know Josh. I knew him back when he was in the legislature. Very well thought of, very connected to the legislature. Looks like a good choice to go in there now to lead the hospital association. But I was surprised. I didn't know Lawler was stepping down. I didn't know Dobson was leaving labor.
Well, we spend some time in this. Dr. Waldron used to be the board chair of NCHA.
Yeah.
I'm the incoming board chair of NCHA. So
Oh,
ECU Health
congratulations.
has made sure that we're at the table for things that drive advocacy and support. That's why we spend our time in Raleigh doing that. And so Steve, also coming from the most rural health system, knew how important the advocacy work with the Assembly is. And I think you're right to say, had Steve Lawler not been there, we may not have as much support coming east as we do now. Our presence there is about selecting his successor. When Steve was planning his retirement, really 2 years ago, we started having those discussions about his retirement. And so Josh fits what we need at this time to help us continue to build the relationships in the General Assembly for them to understand what healthcare is doing for the state and how they can be supportive of this, especially at a time of such recovery that we're all going through.
I need to get Josh on the show and talk about his vision for the association.
He'll do well in that role for sure.
He's a good guy. He's a good choice, so congratulations. All right, Dr. Patterson, let's go back to the emergency medicine department, kind of close this out. We talked about the wait times. We've talked about people's complaints about not getting seen as quickly as they want to be seen and having to wait in the lobby a long time. What is it? Why is it happening? What's going on behind the curtains that they don't see?
Well, I think you can't see what other people are receiving in terms of care, what that looks like. And one of the things I wish everyone could see that was waiting in the lobby or waiting anywhere in the hospital is what's happening for other patients. You never see that team that has descended, like Brian talked about, on the patient who is critically ill, the child who's been in a car accident, the person having a heart attack, the person having a stroke. When those patients come in, we'll mobilize 10 to 20 people in the room with them to start taking care of them, and even more to start taking care of their family as they arrive. And it's beautiful. It's our care at its best. It's what we exist to do, and we really love being there. And I speak for everyone in our department when I say that. And it's not something you'll ever see. You'll never see that. You'll only be able to see your first-person experience of that department. And it's our goal to make that the best it can be. But I do wish sometimes people could see what's happening behind the scenes in terms of care for everyone in that space.
Yeah.
Multiple times a day, throughout the day, that scenario of level 1 to the emergency department, overhead calls go, and physicians run to our emergency department. And that's what we do. We focus on the patient most in need at the time, but we also realize everybody that's in there needs care. And so while we have to triage to the most acute situation, not hour by hour, minute by minute, who is the next most important person that we're dealing with. When we're experiencing higher numbers of people needing more intensive care, it's pulling us further into those rooms with those patients. When more helicopters are bringing patients and ambulances bringing patients, or patients being transferred from other hospitals where they can't get this high-level care, it is an overwhelming thing for us. So in the coming year, as I talked about with recovery and all that we're doing and the help we've gotten from the General Assembly, we're in a position, we're planning now a 96-bed expansion to the medical center. The top 2 floors of our cancer center were designed for an expansion there. That will add.
I mean, he buried the lead. Now we're here. Now we're hearing how you're going to fix this problem.
Yeah. So we have expansion plans now that we're in a position to be able to do this.
Right.
We had been planning for this expansion. We had to get to recovery and be able to do that. And first, recovery of our people. And so as I'm so thrilled of where we are with our ability to retain and get people to join us.
Right.
Then recovery with the infrastructure. We still have to create more pipelines. We're working with colleges and schools to grow more people who want to be in healthcare force quickly. But we also need the facility expansions, and that's coming down the pike. Some operating room work that we're going to be doing. All of our hospitals, of course, are experiencing growth. So this phenomenon of building capabilities in our region, we're working to do across the region.
We got to take a break, and I got to end it here. But this has been really good. We need to get you back to talk more about that.
Sure.
When we can talk about what this expansion is going to look like and how it's going to help.
Yeah,
So,
well, I want to thank you for letting us come, and also have an opportunity to thank our teams, because the stress and strain of this volume, which is the record highest we've ever experienced in the history of this organization by a mile, is a strain. And so the public being frustrated with waits, our team feels that every day as well. And so I appreciate the public's patience. I appreciate their understanding of how to use these resources. And I appreciate the ECU Health physicians and staff for what they're doing every day to have a great organization.
Thank you guys for all the hard work. I say every time I get the chance, God has blessed us with this hospital system here. We're very fortunate to have it. I've watched it grow since it was Leo Jenkins' dream back in 1975, and it's been an amazing metamorphosis of what's happened, and we're so fortunate. Good to see you both. Nice to meet you, Dr. Patterson.
Thank you.
Brian, thank you for coming in.